Shall we move on to the next session? Good afternoon, everyone. I would like to invite you all to our next session. This instruction course will be on management of ocular emergencies. It is important to identify and manage these ocular emergencies that come to your day-to-day OPD, and triaging and identifying prioritizing the cases are important here. So let's move on to the session per se.
First,
Very good afternoon.
first we would like to invite Dr. Preeta Nair. She is at present working as consultant in Department of Oculoplasty and Orbit, Chaitanya Eye Hospital, Palarivittam branch, and she completed her fellowship from Shankara Nethralaya, Chennai, and she did her senior residency 1.5 years there. After that, she joined with us. Over to Preeta for your talk.
Thanks, Jimmy. So, I'll be talking about management of orbital emergencies, know the signs and act fast. So, these will be the categories I'll be dealing with: infection, trauma, inflammatory, and vascular cases. What is an orbital cellulitis? So, it's an orbital inflammation that involves muscle fat, which is caused by pathogenic organisms. It's a potentially life and vision threatening situation. Most common pathogens are bacterial, fungal, and rarely tuberculosis and parasitic are also been reported. Most common source of infection that we usually see are rhinosinusitis. Patient usually presents with a severe periorbital edema with painful proptosis and ophthalmoplegia and decrease in vision. They also give associated signs of symptoms of fever, sinusitis, trauma, and surgery. And urgent imaging is necessary when you see such a presentation, and start the patients on empirical IV antibiotics, which should cover a broad spectrum, and also start on systemic corticosteroids. These patients we can also take an ENT or a neurosurgeon consult based on the case. So this is a 11-year-old boy who had presented with left eye prominence, who was associated with pain and headache since 4 days. An urgent MRI with CT cuts was advised, and the MRA picture showed a well circumscribed oval soft tissue lesion in the medial orbit displacing the globe, and a post contrast rim enhancement with central necrosis. This was suggestive of an abscess. The patient was taken up for an emergency abscess drainage through transcaruncular incision, and the capsule was also excised. And simultaneously, the patient also was started on a broad spectrum IV antibiotics. The thing which you have to keep in mind is the patient should be on a kept on a close monitoring. The vision, pupil, extraocular motility has to be checked. These are the indications for drainage. So, in another case of invasive fungal infection, where the patient also presents with similar orbital cellulitis, it's an aggressive, life threatening condition. If it's identified and treated early, it is curable, otherwise, it's going to be fatal. An urgent imaging is recommended, followed by, to confirm the diagnosis, biopsy or a culture. So, this is another 54-year-old male who had presented with severe proptosis and painful ophthalmoplegia. He had a history, he was a high diabetic. On imaging, this was the picture. You could see a central, peripherally enhancing lesion in the left medial orbit, which is suggestive of an abscess. And in the T1 weighted imaging, you can see a non-enhancing lesion in the supranasal orbit, which is suggestive of necrosis. So the lesion is extending till the posterior orbit up to the apex, into the beyond the apex. So in such a case, this patient had to undergo exentration because in the left orbit, because the lesion was extending beyond into towards the brain. and the right orbit also you could see the lesions. So this patient, an aggressive surgical debridement was done and was also started on intravenous amphotericin B therapy. Transcutaneous retrobulbar injections are also recommended. A close vision and pupil monitoring is important in all these cases. Another case where we can, which is a site and life-threatening emergency, is periorbital necrotizing fasciitis. Usually, the cases present with one-third cases present with bilateral involvement, and trauma, surgery, immunosuppression are the predisposing factors. Diagnosis is usually clinical. So these patients will present with a violaceous discoloration of the skin with periorbital swelling, which presents within 24 hours, and then it goes into gangrenous formation within 96 hours. Management is important, where these patients are started on high dose IV antibiotics, which cover the broad spectrum area, and an early surgical debridement is necessary to remove all the non-viable tissue. A close follow-up followed by repeated debridements may be necessary. You can plan reconstruction later once the infection settles. These complications are expected. So emergencies related to trauma that you see most commonly in your setup will be blowout fracture, orbit, intraorbital foreign bodies, globe subluxation, all these injuries and animal bites. So a blowout fracture, is it an emergency? These patients usually present with complaints of diplopia, inophthalmos, infraorbital hypoesthesia with associated complaints of nausea, vomiting. And when such a patient presents to you, it's important that you advise emergency CT orbits. And if you see an entrapped muscle or orbital fat, it's important that it has to be repositioned back. The entrapped muscle has to be released and the orbital tissues has to be restored back into its position. So this is a case where a 6-year-old boy had presented with complaints of vomiting and diplopia. Urgent CT orbits, we could identify the entrapped inferior rectus muscle, and the patient presented with difficulty in elevation also. So we took him up for an urgent orbital fracture repair. The muscle was released and put in position. So this was the outcome post-operatively. Another condition is in traumatic cases, patient can present to you with enophthalmic picture. So it's important that you advise CT, and to our surprise, this was the condition. So the globe was subluxated into the maxillary sinuses because of a large blowout fracture in the floor and medial wall. So these cases were immediately taken up for exploration and repositioning of the globe, followed by the fracture repair. This is another emergency where you can see this child presented with spontaneous subluxation of the globe, where the globe is displaced beyond the rim, and there is always a risk of tethering of the optic nerve. So mostly these cases can be traumatic or spontaneous or self-inflicted. Cases of thyroid orbitopathy, shallow orbits, space involving retrobulbar mass and lax lids, severe craniofacial trauma are the predisposing factors. So management will be, you have to reposition it back into the orbit, back into the normal position with a Say's manure. Another common condition that you see is types of injuries like globe injury, lid abrasions, and canalicular tear, trauma to the extraocular muscles. So when you suspect an animal bite, you have to have a thorough wound cleaning and rabies prophylaxis in case of dog bites. Do a good thorough exploration and a surgical reconstruction. In cases of intraorbital foreign bodies, we can divide them into organic, inorganic. These cases, if the patient presents with an intense inflammation, purulent, or a siderosis, an urgent removal is recommended. These can be taken up for exploration and removal. These are the indications for a surgical removal. If the foreign body is superficial, sharp, if it's contaminated, organic, or most importantly, if it's causing a functional deficit, yes, it has to be removed. Various inflammations in orbit that you commonly see are like thyroid related optic neuropathy, where you can expect an emergency in case of dysthyroid optic neuropathy, which presents at 5 to 8 cases of TED. So these cases, if you go ahead with an imaging, you can see such a picture where you can see the enlarged ocular muscles and that is compressing the optic nerve at the apex. So a picture where you see an apical crowding or an optic nerve compression, that is important because it's going to be vision threatening for the patient. So always assess vision, color vision, pupil, VEP fields in these cases, and if it's all deranged, take the patient up. The patient has to be started with IVMP 1 gram for 3 days, and then reassess the response. And patient, if is showing a good response, you can start on with a pulse therapy of steroids for 6 weeks along with radiation therapy. Or if there is a derangement in the vision, the patient has to be taken up for an emergency orbital decompression surgery. Another important condition is an orbital compartment syndrome, where retrobulbar hemorrhage, where the acute bleed can cause compression in the optic nerve, and which is sight threatening. So an immediate orbital decompression, lateral canthotomy cantholisis can be done in these cases, and the patient can be started on steroids and anti-glaucoma medications. So, timely recognition of orbital emergencies, prompt imaging and diagnosis, appropriate management, delicate and meticulous surgical technique are important, along with a multidisciplinary team approach. Thank you.
That was an excellent talk, Dr. Preeta, and excellent documentation of external photograph, MRIs, and rare cases also, globe subluxation and globe missing. Those cases that not so common cases that we people usually most of us are first time means see the means seeing the such kind of cases and how to manage such cases. Your means information was very much means helpful to us in our coming practices also.
Our next, our next speaker is Dr. Regina Mohan. She's consultant retina surgeon at Chaitanya Eye Hospital, Trivandrum. Over to you, ma'am.
Good afternoon. So I'll be discussing some retinal emergencies. So whenever we see some retinal emergencies, the first come in your mind is always arterial occlusion. So arterial occlusion, patient comes with a sudden drop of vision, especially in the range of a hand movements or a PL, without any preceding symptoms. Okay, so high risk history will always be there, like diabetes, hypertension, voltage people, and clinically it is very easy to identify. It's because the daring findings like very whitening of the posterior pole, typical cherry red spot sign, and sometime you may be able to identify some thrombi or emboli within the vessels. Even though I said it is easy to identify, sometimes it may be difficult to identify. In the first picture, you can very easily identify this cherry red spot, but when you look into the second and third picture, it's slightly confusing. And the confusion increases when there is a media opacity. So at this point, OCT is a very easy modality that is available nowadays in every OPD. So first picture, you can see there is a hyperreflectivity in the internal layers. That is very typical of an arterial occlusion, and increased internal reflectivity in the inner layers along with the edema shows that it's a acute occlusion. And as the time goes by, the internal reflectivity will be there, but the edema decreases and later it goes for an atrophy. FFA, always it will clinch the diagnosis, but in an emergency situation we are never going to do an FFA. So this is a BRAO. Here patient may not present with a defective vision, can have 6669 vision. Most common presentation will be a field defect. So in these cases, retinitis or retinochoroiditis is a differential diagnosis, but OCT will help you to find the. So what is the management? If it is here, the golden time, it is always said to be like 4.5 to 6 hours. But what we do in clinical practice, at whatever time, up to 2 to 3 days, we do the same management. Because whatever we have to offer because the patient is in great distress because of the vision. So first is to decrease the IOP so that more blood flows to your eye. Second is ocular massage or paracentesis. Both these two modalities will decrease the IOP. Along with that, it will help to dislodge your thrombi. Other is medical management, either vasodilators or blood vessel stabilizers. So when the patient comes to the OP, patient is in OP, you are diagnosed as ERAO. First thing you do is a ocular massage, either with a direct digital massage or with a gonio lens or with the slit lamp you can do. You can give a tab Diamox or an IV mannitol to decrease the IOP on an emergency basis. You can take the patient to the paracentesis, take for paracentesis in the OT. Never do paracentesis in OPD because there always a chance for endophthalmitis. And after this, you should prescribe some vasodilators and antiplatelets and take your time to describe to the patient about the guardal visual prognosis and ask for a detailed systemic and cardiac workup. Now the second thing is a macula on RT. Okay, so in this case you can see this is a 57-year-old male, myope, post cataract surgery. He came with floaters actually. So in the first picture you can see when he presented he had a 6/9 vision. Macula was just on. He had PVD with a little bit vitreous hemorrhage and he was advised for the surgery. Next day, he just came for a preoperative workup and his vision was counting fingers. Okay, you can just see now the macula is off. So, macula on RDs are emergency, especially if it is a superior RD. Next situations are viral retinitis, especially when patients who have history of uh, diabetes, on chemotherapy, transplant patients on Vislon, presents with a retinitis kind of picture, you should always suspect viral retinitis and start your treatment. Okay, so we have different antiviral agents like ganciclovir is there, acyclovir is there, but the Valganciclovir, it is easy to administer because initially its dosage is BD and after 3 weeks you can make it OD. But if the patient is not giving a systemic history, then also you can start antivirals, then you ask for a systemic workup to find out whether what is going wrong with the immune system of the patient. So this is after 1 month of valganciclovir, patient who came with the hand movements got stabilized with the CF1 meter and 660. And now come to severe postoperative inflammations. So whenever there is a severe postoperative inflammation, our confusion is always between a TAS and an endophthalmitis. So whenever it comes very early, next day itself, lot of fibrin, less likely hypopyon and recent good vision, congestion is less, you think of a TAS. Whereas if it is very severe, painful, congestion, lot of hypopyon, you think of endophthalmitis. And here one thing you have to remember is in the first sitting itself you should always take a B scan because it will document your vitreous echoes and will help to assess the progression. And if there is lot of vitreous echo suggestive of vitritis, you should always think in terms of endophthalmitis. And whenever you are in doubt, treat it as endophthalmitis. Okay, so how to start? Start with the topical antibiotics. You can even start with moxifloxacin. But if there is severe inflammation, start with fortified drops. Next is whether systemic antibiotic, it's slightly debatable but always good to start. And first, sitting itself, always go for a vitreous tab, send it for culture sensitivity and gram stain and give a broad spectrum antibiotic. Repeat the injections after 48 hours. And repeated injection should contain specific antibiotic according to your culture and sensitivity report. But what if your culture and sensitivity report is negative? You can always go for a PCR. Okay. Uh, in our institute, since we have an in-house PCR setup, we first sitting itself we ask for a PCR. And whenever the vitritis is worsening, vision is coming down, you can opt for a vitrectomy. Next is endogenous endophthalmitis. Here the infection comes from your bloodstream. So the management is basically targeted towards the systemic foci of infection. The initial documentation should be done with a B scan and OCT, but you should have a very detailed systemic evaluation with blood culture and urine culture. You can take vitreous tab for culture also along with intravitreal antibiotics. even though the main treatment is for the systemic infection, whenever the intravitreal exudates are going high, you can opt for vitrectomy. And the last one, always in emergency, trauma. So in blunt trauma, we know there are a lot of retinal changes in blunt trauma, but one thing you should never miss a peripheral retinal break and small RDs, because 80 to 85% of the peripheral breaks in a post-traumatic case can develop into RD. So do a detailed fundus examination with the peripheral IO, identify the breaks and do barrage as soon as possible. And whenever you suspect occult rupture, you know all the findings of an occult rupture, do a very gentle B scan, find out any disruption of the scleral coat, and if you have any suspicion, always go for a controlled exploration with suturing. And open globe injuries, you may not be able to say what are there in the posterior segment, and never do a B scan in a open globe injury in the primary setting. Your primary mode of investigation is a CT orbit. Okay, then you go for a primary repair and aim for a watertight suturing. If there is intraocular foreign body is there, your view is clear, you can always and you should always remove the intraocular foreign body in the first sitting itself. But if the view is not clear, globe is not stable, you can wait for the primary suture, let the globe stabilize, then go for a foreign body removal. And when should you suspect a post-traumatic endophthalmitis? When there is hypopyon, severe clinical symptoms even after your initial treatment, pain is out of proportion to the injury, you should suspect endophthalmitis. And you should start with the regular endophthalmitis treatment like topical fortified drops, systemic antibiotics, and with severe vitritis, IOFB and RD, you can always opt for a vitrectomy. Okay, thank you.
Thank you, ma'am, for that wonderful talk. It was short and crisp and very informative on management of retinal emergencies. Now let me invite our next speaker, Dr. Deepika. She is consultant glaucoma surgeon from MNI Hospital, Chennai.
Good afternoon, everyone. Thanks for the invite, Preeta and Gemini. So, coming to acute emergencies in glaucoma, there are only a few emergencies in glaucoma, but they are very, very important. So, first and foremost goes acute angle closure attack, which is the primary pupillary block. So, from PG rays, as we know, two of the only main emergencies in ocular emergencies will be, one is acute angle closure attack and CRAO, because you have to intervene immediately, cater to the condition immediately, otherwise it can lead to irreversible blindness. So pupillary block can also be caused due to other causes secondarily, which can be silicone oil, air, lens as such can block the pupil in cases of microspirophakia, or anteriorly displaced lens, and inflammatory causes. Other spectrum, the whole spectrum is lens induced glaucomas, and trauma also, traumatic hyphema and iritis can cause acute rise in IOP, and other rare causes like Poschner-Schwarzman syndrome. So coming to acute angle closure glaucoma, so when you see a patient coming to your OPD with severe debilitated pain and redness and loss of vision, so you examine the patient and then you see severe corneal edema, circumciliary congestion. Vision is usually in the range of 660 to hand movements. IOP will be very high, usually over 50. And if you see the AC, it will be very shallow and mild AC reaction and flare will be there. And the prominent sign in this will be a fixed dilated pupil because of the ischemia. And if you see the fellow eye will show an occludable angle, which confirms the diagnosis of acute angle closure in this attack, in this patient. So how will you manage this patient in your OPD? So in management of any condition involves understanding of the pathology of the condition. So in this condition, so what is happening is there is a primary pupillary block which is causing an iris bombay, and which is secondarily causes angle closure, increasing the IOP and all other signs of acute angle closure attack. So primarily we have to address the first we have to address the aqueous IOP. So IOP can be reduced by aqueous, decreasing the aqueous protection by various drugs. but mainly we use topical beta blockers and alpha agonists. Prostaglandin analogs will be avoided in inflammatory conditions. Orally, azrazolamide 250 mg can be given to acutely reduce the IOP. IV mannitol can be given if the patient is if there is no contraindications to IV mannitol. It's usually given in the dose of 150 to 200 ml, slow IV over 20 minutes. So these can be done to reduce the IOP so that your view becomes clear to do any manipulation. So other things you can do is to reopen the angle. So pharmacologically, pilocarpine 2% eye drops can be instilled, which constricts the pupil and opens the angle. The iris falls back and the angles open up so that there will be some aqueous outflow. So there will be a reduce in IOP. Mechanically, you can do corneal indentation with the gonio 4 mirror lens, which again opens up the angle and helps in aqueous reduction. And a clear corneal paracentesis can be done to acutely reduce the IOP, which further helps in corneal clearing and further management. Along with it, always you have to reduce the inflammation, because all these conditions present with severe ciliary spasm, and it adds on to the pain of the patient. So you have to address that also with topical steroids. But the definitive treatment here is to relieve the pupillary block. So all these measures you are doing just to clear the cornea, to make the cornea ready for clearing the pupillary block, to see a good view of the iris, to make a patent PI. So it can be done with the laser peripheral iridotomy, and in rare cases we can do a lens extraction in such cases, but always and always remember, you should do a prophylactic iridotomy in the other eye as well. So pupillary block can also be caused due to silicone oil, which can be trickled post vitrectomy patients, which can be trickled through the zonules, and it can come into the anterior chamber and block the pupil. So it is a kind of a reverse pupillary block. So here again there is a iris Bombay formation and secondary angle closure, and the following mechanisms is the same, but just the cause of the pupillary block is different. Even a gas bubble, C3F8 or SF6 can block the pupil, and even a small air bubble which is done post cataract surgery, post uneventful cataract surgery, can block the pupil and cause acute rise in the post-op period. Causes in inflammation will include a seclusion pupillae, which is a 360-degree posterior synechia, which will cause iris Bombay and cause high IOP. Occlusio pupillae is just a pupillary membrane, which is again causing an iris Bombay and causing a high IOP. So how will you manage these patients in OPD? First thing is not to get tensed. In any condition of high IOP, you have to just reduce the IOP first with medications, topical, oral or systemic, as in acute primary angle closure attack, and the primary and definitive treatment to relieve the pupillary block will be laser PI. You don't have to wait for pupil constriction or the IOP to come down in secondary pupillary blocks, because it is very difficult to bring the IOP down. You can just take the patient to the laser room and try look for any thin area of the iris, and then make a patent PA. In such cases you have to be careful, because the AC will be very shallow, the iris will be just touching the cornea, it will be just behind the cornea, so you should be careful not to injure the cornea as well. And once you get a patent iridectomy, you can see beautifully the iris falls back, and even the finger tension becomes normal, and in some cases you can even see the cornea clearing immediately. The other lens-induced causes include microspirophakia, where the lens is small. It is a congenital disorder where the lens is small, the equatorial diameter is small, so that sometimes it can get subluxated when the patient is bending forward, or spontaneously it can get subluxated, where it can get trapped in the pupil and cause secondary angle closure, iris Bombay and angle closure. In cases of pseudoexfoliation, the normal crystalline lens or a cataractous lens can forwardly displace and get trapped in the pupil and cause a pupillary block again. So how do you manage these conditions of microspirophakia, where there is intermittent subluxation of the lens? So any condition, you have to first medically control the IOP as acute primary angle closure, but here to relieve the block you can try cycloplegics, because the smaller lens is trapped in the pupil. So once you give a strong cycloplegic, and make the patient supine for 1 to 2 hours, sometimes the pupillary block can get relieved in microspirophakia and the lens can go back to its original position. If still the block is not relieved, you can attempt laser PI. But the definitive treatment in any microspirophakia case will be a lensectomy, vitrectomy with secondary IOL, because they can have again intermittent attacks of this thing, and Sometimes the pupillary block cannot be relieved by any methods. Coming to the whole spectrum of lens-induced glaucomas, so the first and foremost comes phacolytic glaucoma. So phacolytic glaucoma is the release of high molecular proteins through an intact capsule in a hypermature or mature cataract. So usually the patient presents with acutely elevated IOP. You can when you check the AT, the knob moves on. The first patient I saw, the when I was checking the AT, it is going from 0 to again 70. It is coming back to 0. So it's almost more than 70, or it's unmeasurable. So it usually presents with such a high IOP, and the patient presents with severe pain, redness, and discomfort. So main thing is you have to reduce the ocular IOP with ocular hypertensive medication, but the definitive treatment will be removal of the offending agents, which is the cataract in this condition. So you have to plan for a cataract extraction. You can plan under IV mannitol cover, because even though you are trying to reduce with medications, it may not be reduced to that extent you are expecting. Coming to phacomorphic glaucoma, so normally there is a phacomorphic narrowing of the angle, which generally occurs slowly with the formation of cataract. However, in some acute cases, which the incipient stage of the cataract where the lens is swollen, the iris comes in touch with the lens capsule more easily and causes a pupillary block, sudden pupillary block, and in an eye which is not anatomically predisposed, this can happen, and sudden iris bombay and angle closure can happen. There is a controversy in the treatment of this condition whether LPA should be done prior to cataract extraction or not, but the definitive treatment in any case will be cataract extraction, because that is the offending agent in this condition. Coming to trauma, especially blunt trauma, there is hyphema, where there is the dispersed RBCs in the anterior chamber, which can go and clog the trabecular meshwork directly, or the inflammatory debris and the fibrin, which can go and clog the trabecular meshwork, or there can be a direct injury to the trabecular meshwork, which can increase the IOP. There can be many mechanisms, but the patient presents with acutely high IOP and a loss of vision. And in hyphema, the prognosis depends upon the level of hyphema, the grade of hyphema. Sometimes there is a total hyphema where which can again cause the pupillary block and angle closure type of glaucoma as well. So how do you manage these conditions in OPD? So medically, you have to advise first rest and head and elevation, and steroids and cycloplegic should definitely be given to take care of the inflammation and the ciliary spasm which is happening, and anti-glaucoma medications to reduce the IOP should be given. In particular, carbonic anhydrase inhibitor should be avoided in these cases, because in sickle cell hemoglobinopathies, because it can aggravate the acidosis and cause more sickling. Antifibrinolytics agents have also been tried, tranexamic acid, TPA, and aminocraptoic acid, which are mainly useful in rebleeding cases as well. In some cases of hyphema, we need to intervene surgically. The surgery will be an AC wash of the hyphema. In very rare cases, filtering surgery also may need to be done to take care of the IOP. So, what are the indications of AC wash in these patients? One is the corneal blood staining, because when the hyphema is there in the anterior chamber for a long time, like more than 48 hours or something, the corneal blood staining can happen, which is an irreversible damage to the endothelium, which can lead to vision loss. So that is an indication. And any IOP of more than 60 mm for 48 hours can affect the optic nerve, so that has to be evacuated immediately. And any IOP more than 50 mm for 5 days, and any IOP more than 35 mm for 7 days also needs an AC wash. But lower threshold of IOP in these cases has to be kept in mind for sickle cell disease and trait, and also in young children with because they have a risk of amblyopia. So coming to Postular-Schwarzman syndrome, this is a very rare syndrome. Patients usually, it is usually in the younger age. Patients present with unilateral recurrent episodes of acute IOP. They will present you with pain and blurred vision, but there may not be redness as much. It is like a white eye condition. There will be a mild anterior chamber reaction. Sometimes a sentinel KP can be seen. The treatment again will be topical steroids and anti-glaucoma medications during the episodes, but otherwise in between the episodes they may not need any treatment as such. Thank you.
Thank you, Deepika, for that informative talk. It was, you have covered all the emergencies.